talk, Dr. Hishali Jayasundara, a senior registrar in gastroenterology, Colombo North Teaching Hospital, and Dr. Udar is going to talk to us on acute liver failure and update on management. Over to Dr. Jayasundara.
Good afternoon, everybody. So, first of all, I would like to thank the Ceylon College of Physicians for giving me this opportunity. And today I'll be talking about acute liver failure and update on its management. So before I embark on my main talk, I would like to take you all through a brief clinical scenario. So this is regarding this is with regards to a 48-year-old lady who had been previously well. However, she has been recently treated as for an upper respiratory tract infection from a nearby general practitioner, and she was probably given some antibiotics, which she is not aware of. And she has then noted some general ill health, and then icterus, and then presented with altered mental status, which had made her to seek tertiary care. And she has no specific underlying disease, especially liver diseases. And on examination, she was found to be afebrile, and she was icteric with a GCS of 10 out of 50 with flaps. And she had no peripheral stigmata of chronic liver cell disease, and she was only found to have a non-tender hepatomegaly. So, the investigations, as you all can see, so there is an acute derangement of liver enzymes, and also there is a derangement of coagulopathy with a high INR, and the bilirubin is also high. And the basic etiological investigations are almost normal. So with the background history of acute onset and no previous underlying liver disease, and there is a derange of liver enzymes with derangement of liver functions. So all this will help us in aiding the diagnosis of acute liver failure. And in this scenario, it is more probably could be some underlying drug, or could be some other viral etiologies, even though the main viral screening is normal. And also it could be some other unrelated condition like autoimmune pathology. So hope this is an eye opener for my talk, and the outline of my talk is as follows. So first of all, I would be defining what acute liver failure is, and then moving on to the incidence and prevalence of acute liver failure around the globe, and then the difference, the etiological pattern depending on, again, the global distribution, and then evaluation of such patients in our first encounters, and then general management in ward setup as well as in the ICU setup, and then regarding the prognosis, and then the place for emergency liver transplantation, and the newer treatment modalities. So initially, this was mainly defined as fulminant liver failure by two people, Trevi and Davidson, in 1970s, and this was this clinical entity was initially thought to be having a fatal outcome. But fortunately, now due to the introduction of emergency liver transplantation, and also with this clinical care management, now the prognosis has been much better, and there are survival benefits as well. So therefore, in a patient who has been previously well without any underlying liver disease, specifically who is coming with acute derangement of liver enzymes, which is elicited by at least 2 to 3 times the upper limit of normal, along with coagulopathy associated with an INR of more than 1.5 and hepatic encephalopathy, all these will be needed. It is essential to for us to diagnose acute liver failure. But there are exceptions. For example, in conditions like Budd-Chiari syndrome and Wilson's and autoimmune hepatitis, or in the neonates, if it is vertically acquired hepatitis B, these 4 conditions are exceptions because they might have had this liver disease which had not been overt, but their first presentation would be acute liver failure. Having said so, it is controversial in alcoholic patients because even though they can present with severe alcoholic hepatitis, they would have consumed alcohol for a long period of time. So therefore, we cannot consider this as acute onset. So in the then depending on the time duration from the onset of jaundice to the onset of encephalopathy, we can categorize this acute liver failure into several phenotypes. So in the hyperacute setup, normally it takes only about 1 week for onset of encephalopathy from the onset of jaundice. So they will have very high transaminases relative to the bilirubin levels, and also severe coagulopathy as well as intracranial hypertension. But with this amount of liver injury, their survival and their prognosis seems to be much better even without liver transplantation. And the common culprits of this etiology is commonly like paracetamol toxicity or hepatitis A and E. And then when comparing to the subacute cause, now here the onset of encephalopathy takes much later, and the duration can range from about 4 to 12 weeks from the onset of jaundice. And here they have higher bilirubin when compared to the transaminase level. And here their prognosis is very much poor, and common offending agents like other drug-induced liver injuries and other miscellaneous causes could be the causative agents of this subacute liver failure. So when looking at the epidemiology, according to the March consensus, they say in the United States, the annual incidence is around 2,000 to 3,000, and there is a wide discrepancy of the etiology depending on whether it's a developed or a developing country. So commonly in the as you all can see in these pie charts, in the United States and in United Kingdom, the common cause for acute liver failure is paracetamol toxicity, whereas in the Asian countries like Bangladesh, India, Pakistan, it is mainly hepatitis E. And in Japan and Sudan and other African countries, it's the common culprit is hepatitis B. So if you look at this in detail, so most of the drugs are, in addition to paracetamol, causes of this acute liver failure. So we use augmentin, norepinephrine, and flucloxacillin in our daily basis. And however, these are one of the most important drugs that will precipitate acute liver failure. And also certain anti-epileptics like phenytoin, carbamazepine, valproate, and statins and diclofenac. And also these recreational drugs are some of the common drugs. And also the second commonest cause is viral hepatitis like A, B, and E, and less common causes like cytomegalo, herpes simplex, varicella. And in our setup, we always have to exclude arboviruses like dengue and also rickettsial infections. And then we also have pregnancy-related conditions and other vascular causes like Budd-Chiari. And in the elderly population, they usually get it due to underlying cardiopulmonary dysfunction, hepatitis. And also in the Western population, this poisoning is also common. Can you see? Yeah.
Yes, you can go. Yeah.
So do we have a place for liver biopsy in all patients in presenting with acute liver failure? It's obviously no, but there are certain conditions. So for example, if we are in doubt whether it's an underlying cirrhotic patient or not, then we always have to go for a liver biopsy, because when we talk about subacute phenotype of acute liver failure, because it's of a long duration, usually we do imaging, and the radiologist might comment that there is some regenerative nodules and shrinking liver size, and they also have some amount of ascites and splenomegaly. So these are all conditions which are present even in cirrhotic patients. So therefore, that is it, because then we need to exclude cirrhosis, because otherwise cirrhotic patients with this condition do not warrant emergency liver transplantation. So also, if there is a high suspicion whether it's a malignant infiltration, and also if it is in dire need to exclude autoimmune hepatitis, and also alcohol-related patients also do not warrant emergency liver transplantation. So therefore, to exclude these conditions, we have to go for a liver biopsy. And the preferred method is transjugular route because of the coagulopathy and high risk of bleeding. And also there is a place for doing laparoscopic biopsy, but however, because of the giving general anesthesia is a problem with the underlying hepatic encephalopathy. So these are the conditions that do not warrant emergency liver transplantation, like hypoxic hepatitis and other hematological conditions and other infiltrative diseases and infections secondary to like diseases like malaria. and alcoholic hepatitis. So if we find the underlying etiology of this any precipitating factor, then there's a place for treating this and then preventing further liver damage. For example, now if it's a viral hepatitis, we can start on antivirals, or in autoimmune conditions, start on steroid pulses, or if it is pregnancy related, from delivery of the baby, and if it is like Wilson's, you can start chelating and so on. So in the ward setup, always we need to do all the basic hematological and biochemical investigations and monitor the patient carefully. And also it's better to have a baseline arterial blood gas with a lactate level and arterial ammonia levels. And in the meantime, we always have to hunt for the etiology as elicited in this graph, and then also look for the complications, and always be vigilant about infections, because that is the most common cause of death of these patients. So in the routine setup, we always have to, the basis of management of these patients is to maintain the normal physiology and prevent complications and avoid any complications. So a few words about paracetamol toxicity. Now it's more common among the Western population, and the data shows that about more than 60,000 of patients who present with paracetamol overdose, usually about 500 of them will end up with acute liver failure. And here in the initial stages, usually their paracetamol levels can be normal. So without looking for the paracetamol levels, if you're highly suspicious about this paracetamol poisoning, then you can start off with NAC. And if they have presented within at least 12 hours of ingestion, then there's a place for gastric lavage. And with this much of liver injury, usually the transplant-free survival is very high among these patients, and that is a very good finding. So even in non-paracetamol toxicity, there's a place for NAC, and I shall be talking about the uses of NAC in my later slides. So usually we get referrals asking for this NAC regime. So it is basically, you can start off with 150 milligram per kg in 200 ml of 5% dextrose in water over 1 hour. And then in the next 4 hours to continue it as 12.5 milligram per kg per hour. And then in the subsequent 67 hours as 6.25 milligram per kg per hour, which totals to 72 hours. So if you consider the mechanism of NAC in acute liver injury, NAC has both antioxidant and anti-inflammatory properties. So therefore, it will prevent the oxidative injury that is occurring in the liver and enhance liver hepatocyte regeneration and minimize the inflammation. So therefore, these Kaplan-Meier curves have elicited how these patients benefit from transplant-free survival, and it is mainly found to be beneficial among patients with grade 1 to 2 hepatic encephalopathy when using NAC among non-paracetamol toxicity patients. So you can use NAC for a maximum of 5 days, and beyond that, there is a high risk of provoking sepsis. So this is how people have used NAC in our setup in Sri Lanka, and these case studies have depicted, and here they have mainly used among dengue fever patients, and they have had a marked recovery with the use of NAC. So once you encounter such patients, the next question we have to face is whether we need to transfer these patients to tertiary units or not. So depending on the etiology, again, you can categorize it as either non-paracetamol or paracetamol. So these are the clinical criteria, and if you are fulfilling these, you can, so basically if the patient is having any acidosis and coagulopathy and acute kidney injury, as well as encephalopathy with high bilirubin levels, then in non-paracetamol poisoning, you need to transfer these patients. So then if these patients are now managed in ICU setup, then there are certain goals we need to fulfill. That means we need to optimize the condition so that there is sufficient hepatic regeneration, and then always we have to anticipate and prevent complications and assess the native liver, whether it's recovering, and then assess the potential need for liver transplantation. So basically in acute liver failure, almost all the systems will be affected, and I'll be talking about it later on. Now, if you look at the cardiovascular system, now usually the patients initially they are volume depleted because of nausea, vomiting, reduced intake. So initially we always have to resuscitate these patients, preferably with IV crystalloids, and then but you have to make sure that you don't worsen the condition with hypochloremia, and if so, we can use Ringer's lactate. And then volume overload is also detrimental as underfeeding. So always we should guide by certain invasive measures like CVP or any other sophisticated methods in the ICU setup. And then usually patients will have high lactate levels initially because of this volume depletion. But once you resuscitate, you expect the lactate levels to come down. But if there is persistently high lactate levels, that means there is ongoing liver failure, and that is not a good clinical sign. So then even if with resuscitation, if the target blood pressure is not achieved, then you need inotropic support, and the preferable inotrope is noradrenaline. And if there is the requirement is increasing, then you have to adjunct with vasopressin. And there are no specific blood pressure targets defined in literature, but however, they say that if the patient is a young patient and has had no underlying hypertension, a mean arterial pressure of 60 would be sufficient. But if it is an elderly and complicated with acute kidney injury, then it's better to have a higher mean arterial pressure of more than 75. But once a renal replacement therapy is established, they do not give any they do not define any mean arterial pressure. And also 50% of them will have some adrenal dysfunction. But however, the place of hydrocortisone therapy is still a question, because if we use hydrocortisone, obviously it will reduce the amount of vasopressors, but it will aggravate sepsis. So in addition to that, always we have to exclude any cardiac dysfunction with imaging like 2D echoes. And then if there is so, then we have to use inotropic support cautiously like dobutamine. So then looking at the respiratory system, now usually the patients need to be intubated if there is in gross grade 3 to 4 encephalopathy. And if so, then we have to use propofol is the ideal agent for induction of anesthesia, because it's an anticonvulsant, and also it helps to reduce the cerebral metabolism and reduce cerebral edema. And short-acting opioids also can be used, and we have to use lung protective ventilation with a tidal volume of 6 ml per kg with appropriate P pressures. And it's very important to maintain normal levels of carbon dioxide and avoid hypocarbia. And they encourage regular chest physiotherapy so as to prevent these pneumonias. But we have to avoid suctioning because that will provoke a rise in intracranial pressures. And when looking at our GI system, normally these patients will have a high metabolic rate, so they need to be given some form of nutrition. If the patient is not in gross encephalopathy, then you can use enteral nutrition. If so, there is no place for PPIs. But if the patient is intubated and is not fit for enteral nutrition, then you have to use some form of parenteral nutrition. And lipid emulsions are found to be beneficial. And with this enteral nutrition, we always have to be cautious whether the patient is having high ammonia levels. If so, it will worsen the cerebral edema. And also we have to be vigilant about developing pancreatitis. And when looking at our kidneys, usually we have to monitor the patient with output and urine output and creatinine levels, and early commencement of this renal replacement therapy. Ideally, continuous renal replacement therapy is better over intermittent. So then in cases of persistently high lactate levels or high ammonia levels, and if there is metabolic derangements, all these are indications for early initiation of renal replacement therapy. And the brain is one of the most important things to preserve. So we have to always have regular neurological monitoring at least every 2 hours. And if the patient is managed in, should be managed in a quiet environment. And if the patient is having grade 3 or 4 encephalopathy, it warrants intubation. And if the patient has got any seizures, then you have to monitor with EEG and use liver-friendly antiepileptics like levetiracetam. And there is no place for use of lactulose or rifaximin, where we use them in management of hepatic encephalopathy among CLCD patients. And also the use of LOLA is again a question, because it can reduce the amount ammonia, but it has not been found to be beneficial. And also if the patient is having concomitant acute kidney injury, you cannot use it. So it will be very beneficial if we can monitor the intracranial pressure, and it is commonly there are invasive methods, and because of the high coagulopathy, high risk of bleeding. But now we have this transcranial Doppler, which is found to be very helpful. And if the patient is having high intracranial pressures, then we need to reduce it with mannitol and hypertonic saline, and avoid hyponatremia also. And there is no place for therapeutic hypothermia. And if the patient is still having persistent high intracranial pressures, there is a place for giving indomethacin, but it cannot be given very often because there is a risk of provoking acute kidney injury. And CET is only indicated if you are to exclude any intracranial hemorrhage or any herniation, and not to monitor the cerebral edema. So there is always metabolic derangement. So we have to maintain normal blood sugar levels with a target of 150 to 180, and avoid hyponatremia, maintain the sodium levels around 145 to 150, and keep the other micronutrient elements in the normal ranges. And obviously there is a coagulopathy, but if the patient is not having any overt or life-threatening hemorrhage, there is no place for giving blood products. And in case of active hemorrhage, we can give blood for a target to achieve a target of 7 grams per deciliter, and keep the fibrinogen levels around 1.5 to 2, and platelets around 60,000. It's always better to correct these after a thromboelastogram. And infection is one of the major determinants of survival. So usually they get infected with bacterial infections. About 60 to 80% of them will have infection. And commonly it's either some form of pneumonias or even UTIs or line-related infections. So the common culprits are like gram-negative bacilli and gram-positive. So also they are more prone to get fungal infections like candidiasis. So we need to have regular surveillance at least every second or third day with routine set of cultures, and early initiation of antibiotics, broad spectrum antibiotics are necessary, and if necessary, treat with antifungal treatment as well. So prognosis of these patients now, according to the acute liver failure study group, they have put forward a prognostic index, which is a bedside smartphone app. And this predicts the 21-day transplant-free survival, and it's found to be superior to the MELD. And this incorporates encephalopathy and INR, the etiology, and vasopressor use, and the bilirubin levels. So what is the place for emergency liver transplantation? So according to the data, they show that the 1-year survival following emergency liver transplantation in acute liver failure patients is around 80%, and that is a very considerable good indicator. And usual prognostic criteria of these patients are like, we have to always consider the patient's age and the encephalopathy and the degree of liver injury. So usually they recommend cadaveric liver transplantation, and they have not usually the live donor transplantations, because the 21-day post transplantation survival is found to be around 92%, and that is also a significant amount. And the 1-year post transplantation survival is around 80 to 90%. So when you are evaluating and listing patients, there are certain criteria to be fulfilled, and these patients are categorized under 1A according to the United Network for Organ Sharing criteria. If the patient has had no underlying liver disease and is currently having ICU care and is ventilator dependent and is on either CRRT or any coagulopathy, then the patient should be listed. And the contraindications also should be considered. For example, whether there is any psychological barriers, like if the patient has been having some drug abuse or poor compliance with some form of medications, and lack of social support, and also the patient is having severe multi-organ failure and irreversible brain injury. All these are contraindications for emergency liver transplantation. So there are certain other King's College criteria are another setup. So here they have again, you can use it either depending on the etiology, whether it's paracetamol or non-paracetamol induced acute liver failure. So in non-paracetamol patients, if there is a high INR and if the etiology is not determined, and or if there is some like hepatitis or drug induced, and if the patient's age is between 10 to 40 years, and there is ongoing encephalopathy with jaundice, high bilirubin levels, and then if the patients are fulfilling these criteria, then they should be listed for emergency transplantation. So the other evolving modalities of treatment, actually, even though they have tried out.
Excuse me,
Yes.
Dr. Jalsundar, we are running out of time. We can have another couple of minutes to wind up the session.
Okay.
We have a few questions.
So it's only high volume plasma exchange that has been shown to be beneficial, and they have shown to improve transplant-free survival. But the other modalities like hepatocyte transplantation and these artificial devices, all these are not found to be beneficial, and they have no mortality benefit. So the key points before I wind up my talk is early diagnosis of acute liver failure is very crucial, and you should consider NAC even in non-paracetamol patients. And always you should focus on organ-specific management, and then try to maintain the normal physiology and prevent complications. And early referral to a specialized center is required for further care, and consider emergency liver transplantation if there aren't any contraindications. So these are my references, and I would like to acknowledge Ceylon College of Physicians again, and also my mentor, Professor Madhuri Niriyala, and also my other teachers, Professor Arjuna De Silva and Professor Janaka De Silva at Colombo North Teaching Hospital. So thank you, and I would like to entertain any questions.
Yes, thank you very much, Dr. Jayasundara, for that excellent talk. We have a couple of questions from the virtual audience, but I will first give the chargers to ask any questions if they have any questions for you.
Yeah, thank you. Thank you, Professor Jayaratna. I just want to find out the, the figures regarding the paracetamol, the incidence in Sri Lanka. What is the, I've shown one of your slides shows, high incidence of hepatitis E and in Bangladesh and India, which is of course happens in pregnancy. What about in Sri Lanka? What's the prevalence of E and probably the, other causes in Sri Lanka, especially paracetamol? Have you got any figures on that?
So actually, among dengue patients and other lepto patients, we have seen patients ending up with acute liver failure. And according to my knowledge, paracetamol toxicity, of course, I have not encountered much. Maybe because we start off with NAC early. And other viral causes are also not very prominent in Sri Lanka, sir. And also sometimes because of our limited resources, we cannot identify the exact etiology. If so, it would probably be under indeterminate causes, because that is also contributes to about 5 to 10% of patients presenting with acute liver failure.
Okay, thank you very much. Dr. Nandana.
Yeah. So, do you have this liver dialysis, mass or Prometheus or whatever in Sri Lanka? Can you hear?
So
do you have this mass? Do you have this MAS or Prometheus or that liver dialysis in Sri Lanka?
No, sir. We only have this plasma exchange and CRRT, and that's it. Not the other hi-fi stuff, sir.
Right, thanks.
Okay, thank you very much. So we have a couple of questions from the virtual audience, and Dr. Dilshan Priyankara, consultant intensivist, so asking a few questions, and because we have discussed about CRRT, would there be a benefit by CRRT, especially in Wilson's disease with acute liver failure, and will it clear copper?
So actually, for definite management of Wilson's, we need chelation, but we can remove some amount of bilirubin and ammonia levels and prevent progression of the acute liver failure. So it is just a subsidiary management, but we need definite management of Wilson's disease patients.
Okay. And the next question is, do you consider giving NAC in all cases of acute liver failure other than paracetamol poisoning, or only in selected non-PCM related acute liver failure?
Pardon, I couldn't get the question.
Do you consider giving NAC in all cases of acute liver failure other than PCM, or only in selected non-PCM related acute liver failure?
Yes, we do consider NAC in non-PCM liver failure because it's found to be beneficial, and not only in PCM acute liver failure.
Is there any specific diseases that you would consider, or any other cases you can go ahead with NAC? Irrespective of the cause, you can consider NAC in liver failure.
Usually, normally in our setup, if the transaminases are very high, and if the patients are having impending acute liver failure, then we tend to start off with NAC and then hunt for the etiology. So most of the time, we are unable to come to a definite etiological clue, but our main aim is to make get the patient out of the liver failure. So we do start off with NAC.
Okay, thank you very much. So in the interest of time, we'll have to wind the session now. So let me hand over the certificate of appreciation on behalf of Ceylon College of Physicians to Dr. Hishali Jayasundara. Thank you very much for joining with us today.